everyone, today we're going to talk about case control studies. Case control studies are considered a lower level study design. It is still observational, but they're retrospective. The way that we run a case control study is we start with two different groups. One group includes cases, people who have a specific type of disease, and the other group includes controls, people without a disease. And then we look backwards in time, called retrospective, kind of like when we listen to retro music, it's music from the past. And we try and figure out, why did the cases get sick and the controls didn't? What factors might there have been in the past that led to the cases being sick that perhaps the controls weren't also exposed to? We can look at it like this, and what we're doing is we're going from the right-hand side to the left. So even though time moves forward towards the right, in the present, we're looking at a population of individuals, and we're pulling out people who have a certain disease and comparing those to people who don't have that disease, and we're calling them controls. And then we're looking backwards in time, trying to figure out who was exposed to what. Now, in case control studies, we have to be very clear about what we mean by someone's a case. Usually we're looking at new cases that were recently diagnosed. If a case has been diagnosed over a long period of time, it'll be very hard for us to look backwards in time and try and determine what were they exposed to that might have led to their disease. Because if they've had the disease for quite a while, it's hard to know was the exposure before the point of diagnosis or after. And so we like to get new cases of disease called incident cases, and then we try and figure out what were they exposed to. And so when we come up with a definition of what a case is, we have to be very specific. For example, if we're looking at cancer, we have to be very specific about which type of cancer, which stage of cancer, and what method of diagnosis are we going to do to determine if they have that type of cancer. Sometimes we can go to hospital registries or disease registries in order to find patients with certain types of diseases. So again, if we're looking at specific types of cancer, we might go to a hospital that specializes in oncology and try and find cases that way. Finding controls is somewhat similar, but actually more challenging. So when we're trying to select controls, we're looking for people who don't have the disease, but who are at risk of developing the disease. And so they might have to go through, or should go through, the same type of diagnostic testing to confirm they don't have the disease of interest. But they have to be at risk. For example, if we're looking at female breast cancer, we can't have a control who's a male. They also have to be female, and they have to be of the age where they could potentially get breast cancer. So we wouldn't want our controls to be 6-year-old girls, let's say, if the breast cancer usually develops in 30s and 40s. And so selecting controls can be quite the challenge. And sometimes in studies you'll see that they select multiple controls because there can be such a challenge with this, and choosing the exact right controls is not always easy. One way of selecting controls is called frequency matching or group matching. What happens with this type of matching is all of the cases will have already been chosen. And then the researcher looks at certain percentages or distributions of certain characteristics within the cases, and they try and match the controls on those different distributions. For example, excuse me, if we're looking at the cases on the left, we can see what percent of the cases are different ages. And so we might have 10% of the cases that are 20 to 29-year-olds. In the controls then, we will try and find 10% of cases or I'm sorry, 10% of controls who are also 20 to 29 years old. And so what we're doing is matching by frequency. The nice thing about matching is it takes away that variable as a confounder. If both the cases and the controls have identical ages in the two different groups, we can't say the cases are more likely to be sick because they're older, because the two groups are the same. We can do this type of frequency matching on a couple of different things, but typically it's usually just one factor that we're looking at. And so it eliminates that variable as a confounder. Some of the disadvantages is that we have to know all the cases before we choose the controls. And sometimes we're not assessing an association of matched variable with the disease. And sometimes we can't find enough people in each of the different percentages. For example, if we had, let's say, 10% of the cases were between 95 and 100 years old, we might not be able to find controls that match that. Another way of selecting controls is called pair matching or individual matching. Rather than looking at percentages of certain characteristics, with pair matching, we're actually looking at a one-to-one match. And so we're matching one single case to one single control, but looking at multiple confounding factors. For example, if we're looking at a 45-year-old female that's a case, then we have to find a 45-year-old female as a control. If we have a 65-year-old female with the disease, or who's a case, we have to find a 65-year-old female without that disease, who's the control. 53-year-old male with a disease, we match it to a 53-year-old male without the disease. This can be really challenging, and so we might not be able to find controls to match all of the cases, which can be problematic because then we can't use all of the cases that we have. So with pair matching, again, we're eliminating different variables as confounding factors, but it's really expensive and time-consuming to find a perfect match for each case. And sometimes we might not find a match, and we lose that information from that case. The third way that we select controls is that there isn't any matching on anything. In other words, the controls are just chosen randomly as, from different groups. For example, sometimes controls are chosen from the same location as the cases. So if we have an oncology trial or an oncology study, case control study, where we're looking at lung cancer, we might access the cases from that center. Let's say it's a clinic. And then we might choose the controls from the same oncology unit, but those who don't have lung cancer but may have something such as brain cancer or skin cancer. Some other form of cancer would be the control to the lung cancer cases. In that case, we're not actually looking at ages or genders. We're just choosing controls that are convenient. So this is easy or easier and less time-consuming. But in this type of study design, our cases might be really different from our controls. And that might really lead to some false results that demonstrate differences, but it's really not true differences. It's a factor of choosing the wrong type of controls. They weren't a good match for the cases. The fourth thing that we can use to select controls is we can use the case as their own control. This sometimes happens if we know exposure data prior to a case's diagnosis. For example, if we're looking at do certain medications potentially lead to a certain type of, let's say, heart disease, we might know when the person was diagnosed with that heart disease, and then we could look back in their medical records to see were they ever prescribed a specific drug. The nice thing about this is we can use the same person, and so they have exactly the same characteristics, except the controls might be younger, but it's a younger version of themselves. But we don't always have that type of data, and it's not always accurate if there is some data there. And so using a case as their own control is wonderful in some ways because it's the same person, so the characteristics of the case and control are identical. But in other ways, it's very challenging because we may not have complete information. So one of the big problems in case control studies is selection bias. The groups that we're choosing, they may not be representative of the population that we intend. So if we're looking at specific types of cancers, the cases we choose from a certain clinic may not be representative of all types of that type of cancer. And the controls that we're choosing to compare the cases to, they might really be different based on where we're choosing those controls from, whether it be from the same clinic, but people with a different form of disease. We could choose best friend controls. We could choose neighbors as their control. There's lots of different, or we could even choose volunteers. There's lots of different ways to choose controls. But based on the way that we choose those controls, we can get very different results. The other big bias that sometimes comes into case control studies is called recall bias. There are times when in case control studies when we have to ask a patient, what happened in the past? Tell me how much you smoked when you were 13 years old. How much did you drink when you were 13 years old? When was your first date? These things we think we remember, but not always. And so sometimes with recall bias, the people who are sick are more likely to kind of strain their brain to try and understand, why am I sick? For example, if somebody is diagnosed with liver cancer, they might overestimate how much they've had to drink in terms of alcohol in the past, because they're looking to describe what might have happened to lead to this illness. And so recall bias is problematic. If we're looking at people who get sick from foodborne illness, and we say, what did you eat at the picnic? Do you think people always remember what they had? No, it's very hard to remember what we've even had for breakfast. And so recall bias is also one of the big issues with case control studies. So, the advantages of case control studies, it's great for rare diseases because we're starting with the disease and comparing it to controls. And so if there's a rare disease, this is the study design that is the easiest to do. It doesn't take very long to conduct because we're looking backwards in time. We don't have to follow people forward for years and years. It's not very expensive. We don't need many subjects. We can use existing records. We don't have to have any additional risks to these subjects, such as new experimental drugs or things such as that. And we can look at multiple exposures that may have led to that disease. Did you eat the potato salad? Did you eat the pizza? Did you drink the chocolate milk? We can ask many different exposures to try and figure out why people are sick or not sick. But there are disadvantages. People don't always remember what happened in the past. Records aren't always available or accurate. We can only study one disease at a time. We can't have multiple diseases in a case control study because then the results would start getting mixed up. Sometimes we can't control for certain variables. That, when we match on certain characteristics, it helps take that variable out. But we can't always match on all characteristics. It is hard to select controls, so we can have selection bias. It's hard to know sometimes what came first, the exposure or the disease. Perhaps sometimes the disease came first, but it just wasn't diagnosed until present day. And so somebody might have been exposed after the diagnosis, but not known that they actually had the diagnosis. And we can't calculate incidence with this, which is a stronger measure of risk. So that's case control studies. Please let me know if you have any questions.